So good afternoon, everyone. Welcome to this webinar that has been organized by the Uganda UK Alliance for Health. This is a very special privilege for me to be chairing this webinar, which will be facilitated by myself and Dr. Henry Muwonge, who is the country lead of the Uganda UK Health Alliance, but he's the lead for the Uganda chapter. Myself, Nelson Sewankambo, I'm professor of medicine at Makerere University and also a board member of the Uganda UK Health Alliance. Just to get going, there's a lot to be said this afternoon. We have 2.5 hours, but I'm sure those, it's quite long, but will not be enough. So let me be brief in the way of introductions by saying that the Uganda UK Health Alliance, just to remind you or to inform those who may not know, was or is a collaboration between the United Kingdom and Uganda Ministry of Health to support program mutual interest and benefit in the health sectors of both countries, while also fostering shared learning between the two health systems. The Alliance recognizes that Uganda and UK are experiencing the outbreak of COVID-19 at different extents and stages of the outbreak, as you will hear from the presenters, panel discussants this afternoon. There is therefore an opportunity for our institutions and countries at large, as well as individuals at the forefront of the outbreak, to share knowledge and collaborative support in addressing COVID-19 in Uganda and the UK. Here in Africa, Uganda in particular, we are relatively lucky, if I may say, that the outbreak or the epidemic started a little later than it did in the European countries and UK in particular and North America. While it started late, it also has so far spared us to reach the kind of enormous spread and its impacts compared to the European countries and the United States. But so far, 9,663 deaths have been confirmed across the continent. Rather, 461 deaths have been confirmed and close to 10,000 infections on the continent. And of course, these numbers are expected to rise further. The Uganda UK Health Alliance webinar, its objectives is to enable, as I hinted earlier, to enable shared learning on the COVID-19 pandemic between our two countries, and also to foster institutional collaboration on the COVID response between the two countries. We have several presenters this afternoon, and I'll shortly, briefly introduce them. They will make presentations and we have discussions, but the ground rules for the webinar this afternoon will be communicated to you shortly by Dr. Henry Muwonge, who, as I mentioned, is the country lead for the Alliance here in Uganda. At the end, or towards the end, we'll get some closing remarks from Professor Gerard Byrne, who let me take the opportunity to introduce him first among all speakers. That Professor Byrne is the Director of Global Engagement at Health Education England. He's a co-chair of the Uganda UK Health Alliance. He's honorary professor of health sciences at the University of Suffolk and a surgical oncologist. The other speakers, Dr. Charles Olaro is Director of Health Services at the Ministry of Health Uganda, in charge of clinical services. He's a former hospital director, Fort Portal Regional Hospital, and is a senior consultant surgeon. The next speaker, Professor Neil Squires, is Director of Global Public Health England. Professor Francis Omaswa is the Executive Director and founder of the African Center for Health and Social Transformation Initiative, ACHEST. He's a former special advisor to the Director General of the World Health Organization. Professor Mark Radford is Chief Nurse Health Education England and the Deputy Chief Nursing Officer of England. While Professor John Hurst is Professor of Respiratory Medicine at the University College London and honorary consultant at the Royal Free London NHS Foundation Trust. Dr. Bruce Kirenga is a director of the Makerere University Lung Institute. He's a pulmonologist in the Department of Medicine, Makerere University College of Health Sciences, and at the Mulago National Referral Hospital. While Dr. Richard Mugahi is Assistant Commissioner Health Services, Reproductive Health, Ministry of Health, and he's a former Director of Health Office. He's a former Director, District Health Office, Kabarore District. And next is Dr. Josephine and Social Services, Uganda Red Cross Society. And finally, but not least, is Dr. Sheba Nakachubo Jita, who is Country Director, Tropical Health and Educational Trust. He's a former Deputy Executive Director and Head of Science and Public Affairs at African Field Epidemiology Network, AFINET. So those are the speakers and the panelists for this afternoon. At this point, let me invite my co-facilitator, Dr. Henry Mwonge, to give us the ground rules for the webinar this afternoon. Dr. Mwonge.
Thank you very much, Professor. I hope I'm clear and loud to everyone.
Yes,
yeah, thank you. I shared the ground rules. In the interest of time, I don't want to really take a lot of time. I shared them on chat, and one of them is actually to encourage everyone to share, if you have concerns, in the interest of time, to share most of the information that you want to share via the chat. So one of the ground rules will be that all videos will be muted. If I have not muted you as the host, please make sure you mute yourself, because that will help us to have the stability of the connection. 2, we shall have all audios muted unless if you are speaking. So if you are not speaking, please ensure that your audio is muted if the host, myself, has not muted you. 3, we shall encourage everyone to channel all the questions and any concerns via the chat. But in the event that it is burning and you have to speak, please make sure you raise up your hand and we'll choose upon you in case we have to. And I think the other thing I will have to speak about, Chair, is that we shall have a maximum of 5 questions after the first session of speakers. That is after the 3 or 4 speakers have spoken. In the interest of time. That is giving every question at most 2 minutes. And then after the panel topics, we expect to have 2 questions for each of the panels. Time allowing, we may have an extra question, but I think because it's packed, we may have only 2 questions. That means there will be only 10 questions directed towards all the panelists that are going to speak today. Thank you very much, Professor. Those are the ground rules, and I will be emphasizing them more and more via the chat. Thank you.
Thank you very much, Henry. So I think we are now at a good point to get the presentations from our speaker. First, foremost, we'll invite Dr. Olaro Charles to speak about the current situation and response in Uganda. Dr. Olaro. Yes, Dr. Olaro, you are welcome. We can see your presentation, your slides on the screen.
Okay, thank you, moderator. First of all, I want to... Are you hearing me?
Yes.
I wanted first to thank the Uganda UK Alliance for really putting up this together. And I will, for interest of time, I will just keep the first few slides and really go to the current situation. And as we speak of today, that was yesterday, the country had confirmed cases, of which 45 of them were recovered and discharged. And then we have 18 active cases, which are admitted in Mulago and Entebbe hospitals. So as government, you are aware of that we had the first 14 days of lockdown, and now we have the extension of 21 days. And what is happening in these 21 days is really to build up capacity, both at national level, at districts. As you know that our service delivery areas are really district, so that when there is when we lift up the lockdown, we have got the capacity to be able to test, to detect, and be able to take care of any community transmissions. So currently we are doing screening and testing of all cargo transporters, and this is coming up as one of the high risk areas where we need to put our efforts. As government, we've received the 2 mobile laboratories from the East African community, which we intend to deploy, one in Tororo Hospital to cover the eastern border areas. The other one will be deployed in Elego, that's in Amur in the north, will be based in Gulu Regional Referral Hospital to cover those border areas. The capacity to test is there. The challenges definitely is the availability of the testing reagents, because the national Uganda Central Public Laboratory has got a facility which can test 7,000 samples in a day. But the issues definitely is the issues of availability of tests. So we are doing routine testing of health workers in active surveillance and management, because as all of you are aware that we really need to be able to protect our workers. So we need to be able to look up earlier that we don't put them at harm distance. And also if many of them get infected, then definitely it affects the country's response. So we have so far done the ones in Entebbe, we're doing the ones in Mulago, and then also we'll do the surveillance teams across the board. But so far the ones who have tested, none of them has tested positive. Institutional quarantine and testing of all coming entrants. And I want to mention that we get in about 2,500 trucks entering the country every day. We are following up contacts and all alerts. We're involved in risk communication. And particularly in risk communication, what's coming up is the stigma which is associated with the COVID. And I think we really need to have a very concerted effort in this area. A lot of psychosocial support to the community and to the individuals. And then management of the confirmed cases. The public measures definitely continue, social distancing and physical distancing, screening at the points of entry. The country has got 53 gazetted centers of points of entry, but there are more others which are ungazetted. So we are working with surveillance and epidemiology, with testing and case management and continuity of routine services. I want to emphasize that we also need to continuity of non-COVID services so that we do not find that the outcomes and the mortality on this in this aspect are even much more than those which are caused by COVID. All of you are aware of that the lockdown came with a lot of constraint for people to access care, but also the aspect of availability, some challenges of health workers having the confidence to attend to patients. And yet you know that the availability of PPEs is one of the key aspects to protect health workers. I must say that the level of PPEs in the country have been progressively increasing, because this definitely comes from a background of global shortages, most of the rationing of tests and also of PPEs. As a country, there has been optimization of social protection to mitigate the impact, and that's why you see government is distributing food to the population. But as I conclude, we have dispatched teams to the regions so that we, at the time when if we make a decision to lift the lockdown, we have got a capacity at district level to be able to test, to take samples, to be able to quarantine, to be able to do case management. And we want to avoid moving patients. They should be managed at the most nearest point where they are than moving them. So this is what we are working on, and we are so far happy to report that we've been working with different partners this has really been a concerted effort, the multi-sectoral, and definitely being led by the office of the president. And the president has really been one of those, the front runners, and everybody keeps looking on when his next address is to be able to listen to him on the advice of which the country takes. So we need to avoid, I want to conclude by saying I need to avoid shaking hands, hugging at all times. Stay home and stay safe. Thank you for listening.
Thank you very much, Dr. Charles. The chair is, yes, the chair is muted. I'm just trying to get him so that he...
Thank you. I tried to unmute myself and I couldn't. The system was saying you cannot unmute yourself because the host muted you. So sorry about that. But thanks very much, Dr. Olaro. Let's go straight to our next speaker, who is Professor John Hurst, speaking about aspects in the UK and management experiences in the NHS trusts. Professor Hurst.
Thank you. So I don't have any slides to share. I'm just going to provide some spoken comments, and it's my pleasure to tell you a little bit about our experiences in London. We had our first cases at the end of January, And as of yesterday, over 130,000 people have tested positive in the UK. About 4,000 new people each day are testing positive. And sadly, we've had over 18,000 deaths in hospital so far. And our current death rate, our current numbers are a little bit lower perhaps than they were at the peak, but are running at between 700 and 800 hospital deaths per day here in the UK. So you can see that we have a sizable problem. So I'm a professor of respiratory medicine. I'm sitting in the hospital today and have been involved with our response. And it's maybe, I think, important to tell you a little bit about what we did, and then perhaps a few words about some of the challenges that we had. And the first thing to say in the hospital that was important, that we stopped almost all elective work before the number of admissions started to rise. Some of our services are still running around urgent cancer, for example, but the vast majority of our outpatient work and elective work has either been paused, or we found new ways to try and deliver care, for example, by using the phone or by using video consultations like Zoom. And that's important because we're actually seeing a spike of deaths in the UK outside of COVID. So there's a concern that people are being scared about coming to hospital with regular conditions, or are perhaps not receiving the best care that they can for their long-term conditions and acute problems. So whilst COVID is a huge problem here, we're also aware that people without COVID may be coming into problems as well. So the first thing we did then was to stop most elective services. That enabled us to do a couple of things. It enabled us to completely refigure the hospital. So as a attending, as a consultant, it's been about 15 years since I've been working night shifts on site, but that's exactly what I'm doing now. The whole hospital reorganized itself so that different people were working in different roles. So different specialties taking part in acute medicine. So for example, all the junior doctors in ophthalmology are now taking part in the medical rota looking after COVID. And that's given us extra staff and extra capacity, but as you can imagine, those staff needed supporting and they needed some training. In particular, that's been important in expanding our capacity in respiratory medicine. So this is a viral pneumonia, so people are needing support, respiratory support and intensive care support sometimes too. And so we've been able to increase our capacity in those specific areas by reconfiguring and releasing staff from other places. And the hospital is running really now as two different hospitals within the same building. We have a kind of called red and green. Red is COVID positive or suspected, and green is not. So we're trying to keep two separate systems so that people who are coming to hospital with regular problems are not at themselves at risk of acquiring COVID while they're unwell. Elsewhere in London and around the UK, the government has opened completely new hospitals. So a big conference centre in London called the Excel Centre has been turned at very short notice through the help of the British military and others into a new hospital with actually the capacity for up to 4,000 patients. Many fewer have actually gone there at the moment, but that capacity was put into the system. And each existing hospital had to release staff to get there. So that's a little bit about what we did. The last thing that I'd like to talk a little bit about is some of the challenges that we've seen. And the first thing, I guess, is in relation to the people that we're seeing coming to hospital. And although they are coming with COVID, so they're coming because they have low oxygen saturations, breathlessness, cough, for us, actually, many of these people are older and have comorbidities. And so a big challenge is the management of those comorbidities. In a way, managing the COVID, oxygen and support is the easy bit. managing their diabetes and their heart failure and their chronic lung disease is as important and is as big a challenge. You mentioned, the last speaker mentioned staff absence, and that's been a big problem here too. Over 120 healthcare professionals have died in the UK. Terribly, terribly concerning. And actually looking at that, the people who've been dying have not been people in intensive care units, where you might think the risk might be highest, but actually it's people in ward environments, outpatient environments, and that raises the issue of what is adequate personal protective equipment for any particular scenario. And there's been a lot of debate about what adequate equipment is, and there are a lot of challenges getting that equipment to frontline staff. That's a big worry for many of us as working as healthcare professionals. On a practical level, the oxygen supply systems within our hospitals reached their limits. We were using oxygen in so many patients at such high flow rates and needing oxygen to power interventions such as continuous positive airway pressure, CPAP, for some patients, that we reached in certain hospitals the limits of oxygen capacity. And so understanding what that was very important in being able to manage people. We are now at the position where we're discharging people. So over 500 patients have been discharged from here at the Royal Free Hospital, alive and well after COVID. And so as we move away from the peak, we're now starting to think about what appropriate follow-up and rehabilitation looks like as well. And that's going to be a challenge for us going forwards. So I think that's probably where I'll stop. Hopefully that's given you a bit of a flavour of the scale of the problem that we have here in the UK. The way that we reorganized ourselves to try and cope with the influx of cases and some of the challenges that we've seen in managing COVID, both in staff and in our patients. So thank you for the opportunity to speak to you, and I look forward to answering your questions. I'll try and answer those as best I can a bit later on. Thank you.
Thank you, Professor Hurst. Now that I'm unmuted, we'll come back to you and of course to Dr. Olaro in the discussion which follows after the next speaker. So our next speaker is Dr. Bruce Kirenga, who will also talk about the experiences, clinical aspects in Uganda and management experiences. Bruce, you are welcome.
I want to thank you for the opportunity to speak at this webinar. I will give the experiences we've had managing COVID patients here at Mulago Hospital Complex. And if my slides have been shown, I don't know whether they have. I'll describe briefly the Mulago Hospital Complex, which consists of very many healthcare and research institutions here at Mulago Hill, including the Mulago National Specialized Hospital, which has over 1,000 beds in its established form. The old Mulago Hospital with 200 beds. Mulago Women's Hospital with 450 beds. The Infectious Diseases Institute, the Lung Institute, the Heart Institute, the Cancer Institute, and other research organizations which provide care, like Module, like MJAB, and the Case Western Reserve University Uganda collaboration. The Mulago Hospital Complex is basically the largest public health hospital in Uganda, probably the largest in East Africa, and is the main teaching hospital for Makerere University. So our experience with COVID-19, of course, it is small. Like the chair said, God has blessed us and helped us through also the public health control measures that we have few cases. However, as already heard, Uganda got its first case on the 21st of March. And our executive director here at the Mulago Hospital Complex quickly established a task force and invited clinicians to enroll into it, which we did, several people did. And on the 23rd, we were trained by a team of trainers from W.H.O, working with our in-house persons. These are persons who had already experience with epidemics and infection control from the Ebola time, and were trained. On the 24th of March, the screening area was opened for people who know Mulago. That is the former 2A, level 2, which has now been refurbished into a modern ward of 53 beds. Like John explained, even for us, it was the first time in many years as consultants to be on the front line. On that day, I think we were 3 people, all consultants, and we were each screening, I think about 60 people each person, non-stop from morning to very late in the evening. And it was challenging because we are always used to work through medical students, interns, and SHOs. On the second day, we were joined by a team from UPDF and other people from Mulago Hospital, junior people and senior people from UPDF, and life became a bit normal. But that same day, I think it was a Wednesday, that we admitted the first case on level 4, and we divided now between a screening group and a confirmed care group. And then new patients were admitted until when we came to a total of about currently 22 patients. So how did we organize the care of the confirmed cases? At the time these cases were actually brought to Mulago, the national case management protocol was still being developed, still being improved up to now, but we have a draft. So we managed patients according to what we had read as specialists, and also according to case management guidelines from the W.H.O. We had a multidisciplinary team of health workers, internal medicine specialists. I think we were about 4, a pediatrician. We had general practitioners who in Uganda we call medical officers, nurses, pharmacists. We had radiologists and radiographers. We had pathologists, microbiologists, psychologists and psychiatrists. And our leaders were on the ground every day. For example, the executive director was available all the days. The deputy executive director was with us 2 times. Actually, she was the radiologist going in to look at the films of the patients. So that is the team that we had, of course, plus cleaners, caterers, almost everyone in the hospital was on the ground. We used the full PPE in the confirmed case ward, that is level 4. And on level 2, people who are screening had masks, they had goggles, and they had an apron and a Macintosh. I don't know how to describe that, coverall. So we managed our patients. The patients were reviewed by specialist physicians once a day, and as many times as needed. We had a timetable where each physician covered a day. I personally was covering 2 days. However, a team of 2 nurses, one medical officer reviewed these patients 3 times a day, and at each review we charted oxygen, pulse rate, temperature, blood pressure, and symptoms, and other assessments as needed. As you know, these patients have comorbidities. Patients were discharged if they were symptomatic, had completed at least 14 days of hospitalization and had 2 negative PCR tests separated by at least 24 hours apart. In terms of medications, maybe I can give a little bit of the philosophy of the medications. Like John has already mentioned, what actually we see in the lungs of COVID patients is a viral pneumonia-like illness. And if you pick a textbook of viral pneumonia, anywhere you will find it, you'll find actually there are several similarities between that pneumonia and the COVID pneumonia, like the ground glass opacities, the widespread nature of the pneumonia. Of course, the COVID pneumonia is... Okay, I think I've been unmuted. So what I was saying that our philosophy on medications was guided by the medicine, what we already know about viral pneumonias, and also it was guided by the understanding of management of community pneumonia, where we need to cover the typical and atypical organisms. So therefore, our patients were divided into 3 groups. Patients who are completely asymptomatic, did not receive any treatment apart from vitamin C and psychosocial support. Patients who had respiratory symptoms, we provided with them with a combination of oral antibiotics, either ampicillin, cloxacillin combination, and azithromycin or augmentin. And those ones who had evidence of radiological disease and dropping oxygen, they had the option of getting intravenous antibiotics. We treated comorbidities. I may not cover that here, but there was a lot of time spent treating comorbidities, diabetes, hypertension. Some patients developed seizures, bipolar affective disorders, all these were found. We did not provide any specific antiviral therapies, such as hydroxychloroquine and others. So in terms of outcomes, so far now, we have discharged 19 patients. We still have 3 patients on the ward. No patient has been transferred to the ICU or needed mechanical ventilation. We had 1 patient who had evidence of disease, very bad radiological involvement, and dropping oxygen, but we managed to treat this patient, and the patient also was discharged. We also had 1 patient who was dropping blood pressures and had radiological filtrates on the X-ray. We also managed to support this patient, and that patient has been discharged. Briefly, I know maybe I've exhausted my time. In terms of research, because personally I come from the research world of things as well. As part of this, we have established a research group called COVID-19, which is basically looking at epidemiological studies and interventions. And we have 2 projects which are currently approved and are being conducted. We have planned projects that we are implementing. I think in the interest of time, my experiences, I have written them there. One of them is what I think the director, Dr. Olaro, mentioned, the issue of stigma towards the patients, but also health workers, has to be managed very well. Success should be determined by the entire hospital machinery to be involved, from administration to cleaners to laundry, such that everyone is trained and protected against infection. Experience that we have gained here and in other places should be cascaded down, such that no hospitals, I heard the director mentioning a hospital in Gulu and others, starts COVID care from nowhere. So this experience should be shared, including the Ebola experience. Teams have to be multidisciplinary, and everyone has to be trained. I know in Uganda we have a few cases, but we have had a woman who delivered. We had a threatened abortion here in our screening center, and so everyone should be trained so that when we are called upon, we will know what to do. Public health awareness should be undertaken such that we have the information. The information on social media is not standardized. Probably the Ministry of Health needs to pull this up and have some outlets that it controls that gives accurate information. I want to thank you very much and also thank our leadership here at Mulago Hospital who have really been supporting us as we treat these patients. Thank you.
Thank you very much, Dr. Kirenga. That is, you've ended at a good time. We should be entertaining questions now. And we have only 10 minutes in which to have these, the responses to the questions. So my co-facilitator, Dr. Henry Mwonge, has been following the questions as they come in the chat area. So what we shall do now is that he will pose some questions to the three speakers, and we need to limit our discussion to 10 minutes so that we can end on time. So, Dr. Henry Mwonge, can you please proceed?
Thank you very much, Professor. I have one question directed to Dr. Olaro, and that is, it's been asked by one of the participants, and that is Joseph Mubiru, is asking that Dr. Charles, how is Uganda handling the issue of the truck drivers? Will the trucks at the border be sprayed too? Chair, I don't know, should we have the speakers answer question by question, or we can read out the questions and answer them in a batch?
Let's have all the questions.
Okay, fine. The five, okay.
Yes,
okay.
And then they can answer at the end. And if there's more time, we'll get into more questions.
Fine. So that is question one, which goes to Dr. Charles. And then question two was to Professor John Hurst. Professor John Hurst, they were asking that out of the death in the UK, Philip asks, how many of those are children?
That is a short question.
Yeah, so the short question, and then the other one still goes to Professor John Hurst, that how are you handling contact tracing in the UK? So another one is patients in Korea who were initially discharged from care ended up testing positive for COVID again. Has UK had a similar issue?
Okay. Next question, please.
Next question, and certainly this goes to, how has TB affected COVID-19 case presentation and prognosis in the UK? Still goes to Professor Hurst.
Yes, let's move quickly, please.
Yeah, the next question, goes to our colleague, Dr. Bruce. Is it prudent to do a pilot on testing healthcare workers in Uganda in non-COVID centers? Healthcare workers in COVID centers are more likely to have adequate PPE, possibly similar to ICU staff in the UK. We have heard that majority of healthcare worker deaths in the UK are from outpatients and general wards. So it's a question about whether healthcare workers in centers which are not taking care of COVID patients should be tested as a pilot. And I think the last question, which will be going to Dr. Bruce. Is there any evidence of increased vulnerability in the context of people living with HIV? I think that was handled. That one we can leave it. Someone talked about it. Did you at any one point consider using chloroquine or hydroxychloroquine as was recommended by USFDA? I think let's go with those ones, Professor, for now.
Okay, thank you very much. So any of the three speakers, you can address the question that you think is to you. Dr. Olaro, would you like to go first?
Dr. Charles, I'm trying to unmute you, but I think you've also muted. Yes, there he comes.
Is it okay now?
Yes, we can hear you.
I was indicating that the issues of the transporters has been one of the key discussion area, both at the political and regional level, and they are definitely, the discussion is still continuing. And that's why I had indicated that to reduce the turnaround time for accessing results, we decided to put in a mobile laboratory at Tororo and then another one at Elego. But specifically on the question whether we are spraying, at the moment we are not spraying the trucks, but definitely when there's a truck where there's one where there's one test positive, definitely undergoes the and routinely, including definitely our ambulances, which are, we use to transport those who test positive. I think the other question I saw, I think from the chart, was issues of access for the workers. I think it's improving. We're working on it with the partners to see how patients can be able to access services. So gradually this is improving. So we are putting a monitoring system in place to be able to capture. But what we know that definitely if you look at the consumption of the services, there's been a decline, which has been noted, and definitely and we're still analyzing the data because the reporting rates also have come down to almost 55%. So when we are done with this one, then we can be able to see what has been the impact, particularly in the first week, the subsequent weeks. I think, Prof, I will end there at the moment.
Thank you very much, Professor Hurst. Professor Hurst.
Hello.
Yes, please.
So I think there are three groups of questions which I was asked to address. So the first one is about age. There's a very strong relationship between age and mortality. So I was specifically asked about children. The youngest person who's died in the UK was aged 13. But if you look at people a bit older than that, so at a time when we had about 15,000 deaths, only about 150 of those were in people less than 40 years of age. So the risk goes up very steeply as you get above, say, 50-ish, and the risk is much lower in younger adults and is very, very low in children. The next thing was about contact tracing. One of the big challenges we've had in the UK is access to testing and ramping up testing capacity. So we are not contact tracing at the moment in the UK. When we first had cases here, that was the strategy. As the number of cases became higher, it wasn't possible to do that. So people are self-isolating at home if they're in contact with someone who's symptomatic or known to be positive. So there's no contact tracing. And so I can't answer the South Korea question either because people aren't being retested. The last question was asked was about TB. And in addition to the risk of COVID going up in people with age, the risk also goes up in people who have comorbidities. So if you look at people with chronic lung disease, for example, they're at greater risk of severe COVID. And so people who may have had TB and have had post-tuberculous lung disease, you might expect to be in a similar situation. I don't have any specific TB-related data from the UK at the moment. Obviously, TB is less common here than it is in Uganda. So I hope that answers those questions.
Professor Hurst, while you are still there, there was a question from Peter Smith, or questions, and that is, apart from the difficulty of testing, which you face in the UK, how are diagnoses recorded and communicated with Ministry of Health? Maybe that is for you or for Dr. Olaro. Have the EMR systems been able to add these new diagnoses? And how has that information been transferred to the Ministry of Health.
So,
That is extensive work at the EMR for DW, I'm not sure what that means, working on this concept.
so for the UK, hospitals are reporting their deaths daily to the government, and that statistics are then made available. But I'd be interested to hear the Uganda experience.
Okay, great. Thank you very much. We can go back to Dr. Olaro after Bruce has addressed his questions. Bruce, and please keep it short, Bruce.
Okay, thank you for the questions. The first question was about testing health workers in non-COVID treatment centers. I think I agree, but I think before even testing them, we should provide them with PPE commensurate to their level of risk. The other question which I would want to comment on was not given to me, the issue of antibiotics in viral pneumonia. When you look at the literature, patients who have viral pneumonia usually have secondary bacterial infection. And the commonest, of course, is staph. Not the commonest, is strep, but many of them develop staphylococcus super infection. So that's why we were adding antibiotics. I think that was the question. The issue of hydroxychloroquine at the Mulago Center, in the patients that we treated, we did not provide them hydroxychloroquine, but the center in Entebbe provided hydroxychloroquine. So we are kindly now looking at the experiences of the two sites, and when the national protocol comes out, probably we have a unified stand on the use of the hydroxychloroquine. Thank you.
Thank you very much, Dr. Olaro. In one sentence or two, the question of how the yes, the frequency of communication to the Ministry of Health regarding the diagnosis.
The communication of the diagnosis?
Yes, new cases.
Oh yes, Prof. Definitely the results we get on a daily, we get our results on a daily basis, and I think we are looking at that almost between 9 to 10 every day. We communicate what are the results which have been come out of that day. The process of individual, at least that's what we give globally, but in terms of details, we share definitely with the different physicians, or if it's a tracking, then the responsible bodies for tracking, if it's the truck drivers. So the results come on a daily basis. Yes, I am aware in the beginning there were challenges, people were not able to get their results regularly or within a stipulated time, but this we have worked on it, and I think now we are using the same systems which we are using for the rest of the other results previously.
Thank you so much, and thank you very much to all the speakers. We conclude that session there, and we go on to a panel discussion. I have already introduced the panelists at the beginning, so let's go straight to the remarks of the panelists. And they will be addressing very specific questions. Professor Omaswa and Professor Neil Squares, you share 10 minutes, so 5 minutes each, to address the question of how can countries strengthen national preparedness and response plans to the COVID pandemic. Professor Omaswa, you are welcome.
Good afternoon, everyone. Should I switch on my video?
Yes, please.
You need to see me even if it's for a short time.
Yeah, even if it's for a short time.
Yes, yeah, good afternoon, and good to hear the voices also of our UK colleagues and the Ugandan colleagues. Many of you may know, or some of you may know, that I'm stranded in the UK. I can't come back home until the travel restrictions are lifted. I came here to visit my daughter, and then everything happened 2 days before my flight back to Uganda. But I'm in very good condition and being very well looked after. Okay, so that's about me. Now, the topic. Congratulations, the topic is very relevant, comparing UK and her partner in Africa, Uganda. And from the topic which has been given to me, how countries can strengthen national preparedness and response plans. Uganda is one of the best examples in Africa. Since the Ebola of the year 2000, we followed up and put in infrastructure, which now makes Uganda really, under the circumstances, one of the star performers. We have always been in the lead in the continent in terms of preparedness and response to outbreaks. This is because we have a national multi-sector task force led by the Minister of Health, including the police, the army, other sectors relevant to health. And they are, in principle, meeting every month with or without an outbreak. And I think Dr. Olaro can say more about that. And then the lower level arrangements, and there is also a command center. There is a command center which has been there for a long time. The office is just opposite the headquarters of the Ministry of Health, one of those floors, with the full-time staff on it. And then we have in our strategic plans, emergency preparedness and response, with structures which go all the way down to the village health teams. And the public is aware of these outbreaks. And these days when Ebola comes to Uganda, it is 1 case, 2 cases, it's identified by the LC Council, and so on and so on. So what are the lessons here? 1, strong systems all the way. 2, leadership from the top. And the president of Uganda, since the days of HIV, has been very sensitive to all these outbreaks. Whenever there is one, you want him to speak, he will, and you can see the way he is leading the control right now. And then on top of that, there are a lot of documents which are there on outbreak preparedness in Uganda, and of course a budget for this. We need then, in the case of a general discussion, what is it that the countries need? 1, WHO has already issued what is called international health regulations. They guide countries on the capabilities that they need to be able to prepare and respond to infectious diseases outbreaks. And Uganda, by and large, is voluntarily assessing itself on an ongoing basis on this. But voluntary assessments are discouraged now. I was a member of an international committee. We issued our report called The Neglected Dimension of Global Security, the role of infectious diseases. This was 2016. The Secretariat was at National Academies in Washington. And that report is a must read for those who have not read it. It describes in details this particular topic. which we are dealing with. I was the chairman of the Health Systems Task Force, and it is basically for those people who are listening from other countries. Uganda is also cited there as a good exemplar. Leadership from the top, structures which are multi-sector, and then winning community trust so that identification of cases, their isolation and handing over to the health system, then followed by contact tracing. We really got top of Ebola in 2000 because we got trusted people from the communities there, the chiefs and the clan heads and so on. We won their trust, and it was they who were coming forward with patients. And then also those who are discharged from treatment, they are the ones who help them to settle back into the community. So strong leadership from the top, strong primary integrated health care, which is led by the local people themselves, is the way forward. 5 minutes is short, and that is what I can tell you as far as Uganda is concerned for now.
Thank you very much, Francis. Now we will pose questions to you and Professor Neil Squares just straight after the next speaker is done, because we understood that you'll be leaving us shortly. So please hang on, and you'll participate in the questions that are coming. So Neil, the floor is yours.
Yes, thank you. Thank you very much. And I'm following my Professor Omaswa, who I've been following for a number of years in various different roles. So he's set the stage very effectively for the approach to preparedness. The key thing that has been mentioned, the international health regulations, there is a globally agreed system for preparedness, and we've already had a number of joint external evaluations which have demonstrated that a number of countries still have significant weaknesses in their preparedness. But even the best prepared nations are still facing challenges with this global pandemic. So although we can strive to be prepared, then there will always be new challenges which really test the system. And the UK would consider itself to have been very well prepared. We've had long-standing plans for pandemic influenza, and many of those plans were mobilized as soon as we were aware of the COVID-19 threat. And we've been following those plans. But clearly, when issues become a pandemic of global scale, then even the best prepared systems are tested. And John Hurst has already highlighted the fact that we've suffered the consequences of sort of this in terms of levels of morbidity and mortality that we've been experiencing as a result of COVID. But in order to prepare, as Francis has said, strong systems are necessary, and those are, good, effective communication and strong leadership. Anyone who's seen any of the BBC News will realise that currently we have daily briefings by our political leaders and our Chief Medical Officer linked into our Medical Director from PHE or the Deputy Chief Medical Officer from the Department of Health. And that leadership and communication is an essential part of preparedness because we need to ensure that the population is fully aware and on board, because many of the changes that need to be made in order to mitigate risk require active cooperation of the population, and therefore having clear communication strategies is essential. But even within the health system, preparedness requires effective communication of guidance. And John has highlighted the changes brought about in the hospital that he's working in, but those changes are happening and have happened in all hospitals. And it's having the ability to flex your existing systems so that they can reorganize their functions to respond to new threats is critically important. And therefore, developing and disseminating and encouraging people to follow guidance is critically important. But we've already had highlighted some of the challenges we face. So even though we were very rapid in the UK to develop the diagnostic capability for COVID, scaling up testing capacity is a challenge, and we've seen that different systems, Germany's often cited as a good example, already have extensive laboratory networks and can scale up more quickly. So there's a lesson learning that is apparent, and I think an important part of being prepared is also being prepared to learn from an epidemic as it unfolds. Learning lessons is critically important. The other key element is understanding what we don't know. There are still a huge numbers of unknowns. So the risks in terms of the age profiles has been highlighted, and understanding and communicating those risks, and therefore thinking about their implications in terms of which sections of the population do you try to safeguard, and identify mechanisms for trying to protect those who are most vulnerable. And those are things that we all need to recognise and learn from other countries. And an important part of preparedness are these exchanges between countries, so that countries that are more advanced in the epidemic can share their lesson learning with other countries, and so we can all learn effectively from one another, because there are so many unknowns that remain. The other important thing to say is that global cooperation, collaboration is essential. So if all countries work in isolation, then we will not achieve the effect we need. We do need to be supporting one another, and certainly the UK is very much committed to supporting its partners internationally. And we've been working in terms of preparedness with Africa CDC, for example, which is building up a network of national public health institutions. So having a cadre of public health professionals who are able to understand and support the political decisions necessary for effective response to an epidemic is critically important. So I've just broadened the discussion out to recognise that there's an important political and communication dimension to the preparedness challenge, as well as the many logistic and organisational challenges that already exist. But I'll stop there to leave a bit of time for questions.
Thank you very much for those brief presentations. I think let's pose two questions to the two speakers so that in the interest of time. Henry Muonge, can you pose those two questions to the speakers, which have come in from the audience, from the participants?
Thank you very much, Professor Nelson. And thank you very much, Professor Omaswa and Professor Neil, for your submissions. We have some few questions from the audience, though our time is running out. They are saying that some other African nations are combining forces between Ministry of Health and research institutions to strengthen health services delivery, monitoring, and surveillance. Is anything similar planned in Uganda? I think that is to you, Professor Omaswa. That is one question that I would choose out of this, and I think I will choose another one for Professor Neil. So the other one is saying, thank you very much for hosting the webinar. I need to, oh, sorry, that's not a question. Sorry, the questions are coming in as many and we have to choose only two. As already asked above by Synergies, why are UK borders still open? I think this comes to you, Neil. No testing, no quarantine of new arrivals.
Okay, let's stick to those two questions.
Yeah.
Francis, you want to go first?
Oh, yes, Prof. Amanda.
Okay.
Yes.
All right. Okay, now. It's a very, very good question about Ministry of Health and Research Institutions in Uganda. I don't know enough, being where I am now, but I'm a member of one of the task forces on funding, and through this task force, I'm aware that funds are being sought for research. as far as I know, in Uganda right now, the National Task Force has got a scientific subcommittee, and that the members of that subcommittee are drawn from academic institutions. There are people there from Makerere College of Health Sciences and other departments there, and UNRO, Uganda Virus Research Institute, even the private research institutions are members of this. So the Uganda's example there of depending on science, putting together those task forces on various aspects of the pandemic, including the science of the pandemic, is, I think, an excellent example. The questioner may wish to contact the National Task Force if you have got something you would like to contribute in terms of research. But a lot is happening. I'm aware, for example, that the president has directed our researchers to start working on a vaccine. I saw in Twitter that Makerere University has discovered or is done two things: a cheap, quick swab test, and also they have made a ventilator. So Uganda is doing well in that. The only issue I would like to raise at this stage, particularly being a member of this fundraising committee, is how our UK partners can support the Uganda effort. Is there a way we can make a request? And also, very good to see you, my friend Neil. We've been together in these things for decades, and good to see you on this screen.
Okay, if I take my question, so the question was about why the UK isn't testing and quarantining people on arrival and is keeping open borders. This is in adherence with the international health regulations requirements, which recognises the huge impact on travel and trade that happen when people close borders. So we're working within the spirit of that. And the UK response has always been to rely very much on individuals taking responsibility. So our advice to our own population is be aware of your own symptoms, self-isolate if you demonstrate symptoms, and it very much relies upon individual responsibility. That same information is given to people when they arrive, that if they're experiencing symptoms, they should self-isolate for 14 days. So it's trying to avoid that more police state approach of where you immediately test and quarantine people. And hopefully this is more within the spirit of the international health regulations. What we don't want to do is in future epidemics get into the state where the moment there's a disease threat, the whole economy is shut down. We will already suffer massive consequences globally, economically, as a result of this pandemic. And it's trying to avoid that being a repetitive cycle of economic harm, which ultimately causes a lot of damage to the world, with substantial risks in terms of poverty and other things causing death and disability. So we need to try to minimize the global risk.
Neil, are you able to respond to my question?
On the support for Uganda, I mean, the UK has given significant financial support on COVID through the UN organisations, and clearly in terms of coordinating the response, that is critically important. That was about 200 million given last week to the UN family. There's also support being provided for global vaccine research through CEPI. 250 million has gone to that. And the other support, the programs, the DFID funded programs in countries will be redirecting some of their resources in order to support country specific actions. So it would be a question of engaging directly with the FCO DFID office in Kampala to address any questions in relation to funding.
Thank you very much. We must move on, and I'm going to be very strict with time for the remaining discussions. But otherwise, Professor Omaswa and Squares, please, thank you very much for your contributions. So the next two panelists is Mark Radford and Bruce Kirenga. Each of you will have 4 minutes, only 4 minutes, no more than that, to address the question of infection prevention and control. With critical supplies in short supply, how can countries adopt approaches to reduce health workers' risk of COVID-19 exposure? And of course, from the experience in UK, we've heard how they have lost 120 health workers. So, Mark, would you like to go first? Henry, can you unmute Mark?
I think I'm unmuted now. Thank you. And thank you, colleagues from across the globe. I am really delighted to exchange views and ideas, and I've been fascinated to learn about the experiences in Uganda as well, which is really interesting to hear, to share our plans today. Much of what you will have heard in both the media and some of our discussions obviously does concentrate quite a lot on some of the high-end science in relation to not only diagnosis, management, treatment of some of the unwell, serious unwell, and also in relation to testing. But as you will all know, much of the core of good practice in relation to pandemics is high quality infection control practice, be they cleaning and as well as also importantly hand washing and a range of other strategies that can be deployed to reduce onward transmission. So much of our focus around core infection control practice has been about supporting organisations and hospitals in England with ensuring good quality cleaning, as well as also reinforcing established protocols in relation to hand washing. What we do know from some of the anecdotal evidence is that other infections have also reduced during the pandemic, which some have hypothesized has been as a result of improved hand washing within hospitals. There will be clearly more research required into this, but it does reinforce the point that some of our core and basic approaches to infection control have very important and large-scale impacts, as well as some of the more interventional assessments that we do. You will have seen much from the media that the supply of PPE has been sporadic at times within the United Kingdom. And I split out a number of issues in relation to this. One is the international nature of the supply of PPE now in terms of it being a global product, where global demand was very significant. So traditional supply routes into different parts of the world into the United Kingdom became strained, which meant that there were particular areas of limited availability, and one which was the use of full-length gowns became quite critical. So new supply and also domestic production was increased to be able to meet that. We always had quite excellent technical data and advice from Public Health England, who were very clear and responsive to any changes in evidence that were required to issue guidance to clinical practitioners. There was a very good network where this information was devolved out to clinical practice to align with supplies within the service. So that has always been very helpful to have very good advice on what PPE to use and when. But of course, we understand that there is the psychology of our healthcare practitioners in these sorts of environments where the fear of infection drives some challenges and sets of behaviours. Mostly of our healthcare practitioners are worried about infecting their families and also infecting other health workers, or also that they may be asymptomatic and be spreading the virus to their patients. And this is alongside some challenges that our health workers have a duty to come to work, duty to their employers, and also duty to their colleagues. So find whilst there are some challenges in relation to PPE, we also understand that some colleagues have had some real concerns in practice in relation to both their own infection control practice and also the impact that has on others. And in some cases that has required some healthcare practitioners a desire to have the highest level of PPE required in different clinical circumstances, the situation arose. And again, good advice and support from our Public Health England colleagues has been really helpful. But one can't underestimate the requirement to have good local training in place within institutions that deliver healthcare, be they in homes or be they within hospitals. It is really important the training of people who are giving direct care is in line with the advice given by national advisors in relation to PPE, which is quite critical, ensuring that not only where you have limited supply it's used appropriately, but also importantly that they're using it to reduce the chances of infection. As you will have noticed in both other European countries and the UK, a large number of healthcare workers have become infected and have sadly passed away as a result of the infections, some of which would undoubtedly have been caught during their work. But there's also other questions in relation to testing, and as I think Professor Squires pointed out, and others, we don't have widespread contact tracing within the United Kingdom, yet we do have a very strong programme of testing for our healthcare workers. There is, as new evidence and new science is advising us, an increased rate of both testing of healthcare workers, not only to give them a diagnosis, but also to, again, support their ability to return to work when appropriate, recognising that the COVID pandemic has increased the levels of sickness and absenteeism for work as people self-isolate or become unwell. So people returning to work is a key factor, but also in terms of being able to reduce transmission by self-isolating individuals. So again, related to some of the issues and challenges we've had in relation to those colleagues who may have been asymptomatic. So there's wide-ranging sets of infection control practices. My take-home messages are reinforcing the core basic standards of good infection control and hygiene, including hand washing and cleaning are fundamental, training and support of people who do domestic cleaning in hospitals and organisations, as well as training alongside PPE, strong advice from nationally around the standards and data for the PPE requirements, but also importantly, a good dialogue with healthcare professionals in relation to support of understanding the psychology of the pandemic in relation to healthcare worker behaviour and the anxieties that may bring to them are some really important areas that need to be understood.
Thank you very much. Bruce, what would you like to contribute to that in 2 or 3 minutes?
Okay, thank you. What I can say after that extensive presentation on PPE is that PPE is very important. All of us at our center, and I think at the Mundeli Center, who have been treating these patients were recently tested and were all negative, despite the intensive contact we had with these patients. So PPE is very important. Second, the PPE is in short supply. So therefore, I want to suggest about 3 things, how in Africa and Uganda we can deal with the shortage of PPE. The first one is each health worker should be confident when they sit to see a patient, someone with a fracture, someone with intestinal obstruction, that this patient probably has no infection with coronavirus. That confidence will improve the quality of care that people provide and the outcomes of those patients. So therefore, I would think that we need to institute a 2-stage screening process in every health facility, where we will leverage our volunteers who we have used in HIV, in TB and other diseases, where we have a volunteer outside the health facility in open air who has been trained to quickly screen the patients before they access any service in the health facility. During that consultation, we need to have a significant amount of social distancing, where which we have also used in other respiratory infections like TB and others. We have a person have been treating TB for about 15 years now. And through that kind of, if you come to our TB centers, you find that we have areas which are well aerated, where our consultation tables are bigger such that the patients are not close. The second one would be to map the Ugandan situation. Where are the concentration of the cases, such that people who are remote from the cases, they would more likely fall into the third recommendation, which I would want to make. That we look at PPE in 3 levels, which are called PPE rationing, where we have minimal PPE, probably an N95 and gloves if needed, medium PPE where people have eye protection and other exposed body area protection, and full PPE. For the medium, it would be like for anyone, if the first stage of screening of patients has happened, then every health worker can have minimal PPE. People who are dealing with people who have respiratory complaints can have medium PPE. And then the full PPE would be for people dealing with confirmed cases. But lastly, maybe to re-emphasize that I think a lot of effort should be put on making PPE available through all means, including local manufacturing and other means which I don't want to go into which have been researched of even considering the use of PPE if things really get out of hand. Thank you.
Thank you very much. For our listeners, please, we will discuss selected questions after the next 3 presentations or discussions are complete. So just be patient, the discussion will come at the end. And meanwhile, Henry, please pick the 2 questions that have arisen here and we'll discuss later. Now, let's go on to address the question of how can health systems ensure continuity of access to routine health services in health facilities whilst managing COVID-19. Bruce, if you can get started and say in 2 minutes, how can we ensure continuity of access to routine health services? And then John Hurst will come in after that.
Topic was, Professor?
Yes.
I think you've missed one of the questions, which is on surveillance and epidemiology.
It is because of time. I did it deliberately.
Okay, fine. Okay. That's all right, Prof. So who is coming next?
Bruce.
Okay, thank you again. Probably I start from where I stopped. It is critical that the other health services continue, especially for infectious diseases, which can actually also get out of hand, like HIV, TB, and other diseases. One thing which I have picked up is we need to build the confidence of every health worker who is seeing a patient for whatever reason that they are safe. And like I suggested earlier, is to have a tiered screening such that by the time I see a patient in front of me, I know some level of screening has been done. Provide PPE, but universal PPE will not be possible where we are at. However, also we can go back to what I had suggested, that we also have a rationed PPE depending on the risk and the mapping of the problem. Other innovations can also be undertaken. I have had some of them, where consultations, like for patients who are coming back for refill, consultations can be done telephonically from wherever the patients are. Platforms can also be created where patients can post questions, such that only the critically needed physical consultations are done. The other idea, which I do not want to go into so much because beyond my capacity, is the issue, since the cases in Uganda are still few, of creating dedicated treatment and screening centers such that the health facilities are freed from the management of COVID-19. I have seen actually a hospital where almost all the other health services completely stopped. It's only COVID-19 care, and you can imagine the people who were using that health facility before, or that service where they are seeking care. You don't want to imagine. So in this sense, actually what I want to say is we need to make PPE available, but use it sparingly, but also create confidence in health workers that not all the patients actually have got COVID. Thank you.
And John Hurst.
Thank you. So a couple of aspects to this for me, very briefly. One is the importance of continuing chronic care for long-term conditions, and secondly is the importance of still managing other acute presentations. So we've seen the volume of cases coming through here on our acute take fall by about 2/3. And anecdotally seeing people presenting with more serious conditions because they've been afraid to come to hospital potentially. So I agree with Bruce that in terms of planned care, we can think of innovative ways of delivering that. So telephone, video conferencing, and I've been hugely impressed by NHS colleagues at the sort of scale and pace of change in the way that we've adapted our outpatient models. We can also support task shifting, so supporting primary and community care services from secondary care has been another way of continuing with important care for long-term conditions. With regard to urgent care, I think there's a public awareness piece there, reminding people that it's still okay and necessary and important to come to hospital if you're unwell. But when those patients are coming to hospital, we've been streaming them separately. So we've been having red and green areas within the hospital for suspected COVID, non-COVID, and then of course attention to infection prevention control is the way to keep those people safe when they're coming in. So ongoing care of NCDs and the ongoing ability to manage other presentations, super important and mustn't be lost in all of this.
Right. Thank you, Bruce and John. There's background noise there. Now we can go back to the question which Henry was saying that I had skipped. Now that we have caught up a little bit with the time, so we'll discuss the question of surveillance and epidemiology. What are the best strategies for testing information flow and risk assessment? And here we have three people, Dr. Richard Mugahi, Neil again, and Josephine Okwera. If you can each take no more than 3 minutes, please, so that we can finish on time. Richard, the floor is yours. Richard, Henry, can you unmute Richard?
Richard is unmuted, but I think we can start with Josephine, who is already, I think, prepared. Richard is unmuted, but he's not talking.
Yes, good afternoon, everyone. So my question relates to the issue of the lockdown, and I was asked to briefly explain what's the value of a lockdown in controlling the spread of COVID-19 pandemic. Now, it is well known that the means of transmission of COVID-19, and basically it spreads through droplets from infected persons. So we also know very well that some infected persons are symptomatic, or they may show very mild symptoms, and therefore the spread of the disease can move very quickly, even when symptoms are not visible. So in the absence of a treatment and also a vaccine for the infection, what is more feasible or logical to do to control the spread of the disease is to seize most of the human contacts, which in a way has led to lockdown situation in most of the countries, just to try and emphasize the physical distancing or social distancing. So generally, a lockdown helps and is necessary to break the chain of transmission, and also to help test interventions. For example, the testing and isolation, if it really works and if it's effective among the populations. The other thing that a lockdown would help with is to try and flatten the curve, because when people are no longer in close contact, the transmission is going to be interrupted, and therefore, instead of having so many people turning out positive around the same time, at least you have a longer time frame, and this will avoid overwhelming the health systems, because in Africa especially, and Uganda inclusive, the health systems are still fragile, and so having so many cases coming up at the same time would overwhelm our health systems. So a lockdown is necessary to buy time, in other words, so that we can have fewer patients coming in at a time that the health system can manage. And in particular, Uganda lockdown was called into place for a number of reasons. When the first case was confirmed on the 21st of March, at that time, before that time, we were allowing in travelers to come in from various countries, and there were certain countries that were categorized as being at high risk. So a lot of focus was being put on those countries that were categorized as being at high risk, while other passengers were being allowed to go and do self-quarantine at home. So when the first case came in from a country that was initially not under the category of very high risk, that made the health experts to begin thinking that probably there were a lot of cases that were missed. So part of the activities that the lockdown in Uganda has helped with is for the health expert to go back, and the epidemiologists to try and trace the over 18,000 travelers who had come in before the first case was identified and test them. We were no longer relying on just signs and symptoms, but also looking at lab testing to confirm or to clear somebody of COVID infection. So basically, the goal of the lockdown in Uganda was to control ongoing spread and also to limit transmission to new geographical locations. And the objectives were quite clear. There were 4 main objectives. The first objective was to enable the country be able to define where the virus was, because of these large numbers of travelers who had been coming into the country. We did not know at that point where these travelers had gone and what their COVID status were. So time was required to have a lockdown so that we minimize movement and spread while we trace these travelers and try to obtain tests from them. The second reason was to have the implementation of safe containment measures enhanced, because at that time our quarantine was not yet well streamlined. So it was defined who would be quarantined and how they would be quarantined and how then they would be released from the quarantine. The third objective was to limit the number of cases requiring critical care. So basically here, there was a plan to decongest the higher level health facilities to provide room for facilities to treat those that will require to be treated in the ICUs. And this also allowed time to have the plan for decentralization of services, of the COVID services to our regions and districts. So the health facilities at the regional and district levels were they started preparing to be able to handle the mild and less severe cases of COVID-19, while the most critical ones would be handled at the higher facilities like the National Referral Hospital in Mulago. Now, the fourth objective of the lockdown was to enhance community understanding of the risk and measures instituted. So the lockdown was targeted at also ensuring that we enhance the community communications, because at the time when the lockdown came in, we had not yet done extensive community sensitization. So during the lockdown, one of the focus was also really to intensify our community engagement and risk communication to make sure that the community understands, because it is well known that communities are very instrumental in any disease prevention. When the communities understand and they come up with their own ways to contain the disease, it's more effective than when things are prescribed to them. So the plan was also to have community engagement and risk communication intensified during the lockdown period. So generally speaking, the lockdown is helping Uganda quite a lot in terms of containing the transmission, but also in terms of giving the health system time to prepare and to be able to manage. Yeah, thank you.
Thank you very much, Josephine. Is Richard available now to comment on that issue?
Richard is available, but I'm not sure why he's not speaking. He's unmuted very well, but I'm not sure why he's not speaking. But I think at the time when we are waiting to hear from him, maybe as a technical challenge, Neil could take a go on the question.
Let's now, there's Neil, who is also supposed to speak on the value of lockdown. So let's hear some comment from Neil. And probably Josephine, during discussion time, we would want to comment on whether actually lockdown in those congested places where many of our people live, and also dependence on, earning daily income to survive, whether you think it is actually effectively working. But before we go there, Neil.
So I'll kick off first with the testing strategy, because that is key to knowing whether lockdown is working or not. So our ultimate goal is to test anybody who needs a test, and the ambition is to be able to do up to 100,000 tests a day. But we're getting there in phases, and there are 5 key phases. Our first strategy has been to boost the swab testing capacity, and we reached our ambition of having 10,000 tests per day by the end of March, but we're now committed to 25,000 tests a day by the end of April. There's in parallel a strategy to boost the commercial partners who are delivering commercial testing, which will take us up to 100,000 tests a day. A key challenge is around developing antibody tests, though, to detect people who've had the infection and whether you can then assume that they have a level of immunity. The idea is that those would be done at home, but one of the challenges is finding reliable antibody tests that are sufficiently specific and sensitive. We are then also have major surveillance studies underway, with some of the biggest surveillance surveys in the world currently being planned to try to get a sense of the population prevalence. This is done using high accuracy antibody tests, which are operated by PHE. And these tests will help understand scientific understanding of levels of population immunity. We also want to develop a diagnostic industry that has the capability to scale up over the longer term. So we're seeing this as an opportunity to build up essential capacity. Some of the key challenges have been the accuracy and reliability of tests, and we're working with a number of companies to try to evaluate and validate tests. And then the other challenge is getting the right supply of people, lab space and equipment and chemicals in order to undertake the tests we want, which is a major logistic challenge. So without that information really on whether people have got the infection, then knowing when and how we can reduce lockdown is one of the key challenges we face. At the moment, we're looking at death rates and the plateauing and the capacity of hospitals to understand. And the idea is to gradually start reducing the lockdown and almost titrating the response in relation to the ability of the health services to cope with the burden of disease. But the government has been very cautious about stating what the exact strategy for relaxing the lockdown is, because they don't want to raise any false expectations, which they think might undermine the population's commitment to continue to adhere to the social isolation policies. Over.
Thank you. Richard, is Richard back? And he can comment on both.
Yes, I'm back, Professor.
So if you can comment on the testing strategy as well as the lockdown, that would be great. In 3 minutes. Yes, and the lockdown.
I kind of missed some part. My network wasn't very clear, but I'm more grounded in the quarantine work. And
Okay.
I will give an experience basing on the quarantine background in relation to the lockdown.
Great.
Our biggest numbers were received initially coming from travelers who were quarantined in selected institutions. And over the time, now we are seeing the numbers of people in quarantine from all our entry points coming down. And to me, this is an indicator that when we have a lockdown and limit the number of person-to-person interactions, then also the number of people coming into quarantine who are high-level suspects for COVID-19 is also coming down. It's a correlation that I think has a backing of how a lockdown is impacting on us detecting more cases that or suspects who are coming into quarantine. The other issue that I think is also coming out clearly is the social issues that relate to quarantine and people getting back into their communities, something that I called reintegration. Dr. Olaro had talked something about it, the social kind of support that we are giving to people who are in quarantine and how difficult we are finding it to reintegrate them into their communities. As I had earlier mentioned, some of the people we quarantine are actually travelers from other countries. And in our protocols, we want to deliver after the quarantine period, would like to take these people back to their communities. So the challenges we get people who are not actually Ugandan and they were held here because of the lockdown. And we need to reintegrate them into their communities. So what we are doing currently is working with the border security systems of our country and the one of the other countries, specifically DR Congo. So we transport our residents who have finished their quarantine period to the border security of Uganda. And the border security of Uganda works out a handover system to the border security of DRC or any other country. This problem is not quite big, but I must say like 5% of the people who were being quarantined were travelers and had the same challenge. So it becomes an issue really for us during the lockdown period. I think that's what I had to comment for now.
Thank you so much. So that takes us to the discussion time. Henry, can we get no more than 10 questions? So 2 for each section that are, where we have had a discussion, and then our panelists can have a brief response to each of the questions so that we can move on to the next step.
Yeah, thank you very much, Professor. I'll let my colleague Solomon read out 2 questions for each of those 3 different panels. I've been attending to many things, so I couldn't really concentrate on the questions. Solomon?
Okay, thank you very much, Henry, and thank you very much, Prof. I'll read out the questions. The first set of questions, I'll go to Bruce and Mark. The question to Bruce is, does the Ministry of Health have a PPE guideline that includes PPE use for the health workers and other frontline workers and the general public? That question goes to Dr. Bruce Kirenga. Then the question to Mark is relating to the politics and the availability of PPEs. The question is, are the death rates in the UK related anyhow to the political situations? That will be answered by Mark. The next question goes to Dr. Josephine about lockdown. When is the series of lockdowns likely to end? The other question goes to Neil. The question is, what exactly is involved in the UK COVID-19 testing strategy? Because there are many tests that are being done with no contact tracing. The next question was going to Dr. Richard Mugahi, and it is, how are you coordinating your quarantine with other East African countries? Then the other question was going to all of the panelists, and I think probably it will be taken up by the clinicians. Is vaccination the only end to this COVID pandemic? Some of the questions that have come in as I was reading those, they are not specifically to anyone, but I'll read them out anyway, so that Prof, you can see who to answer them. The first of those is, are we monitoring the recovered and discharged from infection or antibody titers? The other question is East Africa and Africa learning from Europe and North America? Probably is East Africa learning from the epicenters. The other question that came in is, given the low numbers of new cases in Uganda now, will it be prudent for Ministry of Health to turn attention to validating this by channeling resources to population-based surveys that will check the prevalence of COVID in the population and the different subgroups? So far, those are the ones that are in.
Yes, I think those will be enough given the remaining time. So let's start with Bruce. Each of the panelists will have an opportunity to address a question. I did not hear a question addressed to John, but John, feel free to pick up on any of the questions and respond. So Bruce Kirenga.
Yes.
And let's be brief, everyone, so that, yes, we can recover lost time.
Thank you. Probably the issue of the ministry PPE guideline could also be commented on by Dr. Olaro. But I know there are draft guidelines which are being finalized. My comment on PPE was based on my experience at the front line. The PPE goes very, very fast, and we need to start early to see how we can use it sparingly despite the fact that we have enough now. Quickly, the patients who have discharged from hospital, we have set up follow-up clinics. We'll see them in 2 weeks, and we'll continue to monitor them if they develop other symptoms or other problems. Thank you.
Charles, any addition to that question? Charles Solar?
Can I go next?
Chair, I think in the absence of Dr. Charles, maybe Dr. Mugahi could give something if he has something to comment on that on behalf of Ministry of Health. Dr. Charles is off now.
Richard?
Is this in relation to PPEs, Professor?
Yes.
I think the PPE policies that are being developed, or those which are already in place, they've Dr. Bruce has clearly made a mention about them, and there's a lot of work in progress under the community department of the Ministry of Health, Community Health Department of the Ministry of Health, that they are developing guidelines for PPE use for people who are, because currently what we are seeing is that everyone can especially have gloves and face mask, disposable face masks, but we don't have clear guidelines as a ministry, but the Department for Community Health is working on that, and I think very soon we should have that. We did not include this in our quarantine guidelines. The quarantine guidelines only capture for the service providers. That's what I can say for now.
Thank you. Mark Radford?
Yeah, am I unmuted now? Excellent, thank you. So my question was in relation to the worrying news that surfaced over the last 48 hours of one of our hospital chief execs receiving death threats from members of the public related to PPE. The specific circumstances are that in one of the approaches that many hospital leaders are taking to appraise the public of the impact of coronavirus, in limited circumstances, TV crews are coming into hospitals to demonstrate the effect of working, and also importantly to send an important public health message about, and the hospital in this case brought a TV crew in who demonstrated the challenges faced by hospitals, again as part of a kind of wider public message, but also the use of PPE, which because of the shortages that had been reported, generated quite a lot of local interest, and of course unfortunately for some people that meant that they thought that they were wasting PPE, and the chief exec and hospital was not doing the right thing in his approach. I think there's been quite a lot of support that getting public health messages out about the impact of this and the severity for certain groups of our population are quite clear, but obviously the shortage over the last few weeks in some areas and some types of PPE have generated quite a lot of both media interest as well as also concern from healthcare workers and also for members of the public. And it has become quite a political story, and has meant that politicians and ministers have had to repeatedly, as part of the briefings from our government, respond to the issues of PPE. I think that this threat that was posed against one of our hospital directors, chief execs, will probably reignite that issue once again in terms of both public attitude, supply, and also related to issues and challenges of PPE on the front line.
Thank you. Josephine?
Yeah, thank you so much, Chair. The question that was addressed to me was regarding the lockdown, and when is it expected to end? Is it going to take the 18 months that it will take to develop a vaccine? So in the case of Uganda, if you remember, we all started with a 14-day lockdown. That was from the 1st of April to the 14th. However, on the 14th, it was deemed necessary to have it extended for the reasons that I already went through before. So there was an extension for another 21 days from the 15th to the 5th of May. So when we get to that, I believe there will be an assessment at the national level by the health experts who will advise the president on what next. But generally, WHO has given guidelines as to guide countries on how to lift the lockdown situation, or how to slowly take down the measures for the lockdown. And among them, it includes, of course, having transmission that is under control and a health system that is able to detect and treat effectively the cases that would be identified among the 6 things that was listed. So I believe after this lockdown of the 21 days, if the assessment shows that Uganda has now contained the transmission and is able to detect and effectively treat the ones that have been detected, then probably the lockdown would be lifted at that point. But that's only for the president to determine. Now, Chair, if you could allow me just a few more minutes to comment on some of the questions I'm seeing on the chat group, which I think are very critical issues. I would take a few minutes.
Just 2 minutes.
Yes, okay. So there's a question that has been coming up about the response in the refugee settlement and any plans to support people with mental health conditions. I know for the refugees, I'm not very certain about the plans for those with mental health conditions, but because Uganda Red Cross, we have a lot of interventions within the refugee settlement. I know that the office of the Prime Minister earlier on, when the lockdown was instituted the first time round, issued out guidelines on how the refugees can observe infection control and prevention measures. And among that, it was emphasized that there should be also a lockdown at the refugee settlement where no new cases will be, no new refugees would be admitted into the settlement, plus those in the settlement, their movements out of the settlement were also limited, because clearly for the case of Uganda, the threat is from those coming from outside. So there was a limitation that until the lockdown is over, the settlements are not going to be receiving new refugees. And then plus all the other precautionary measures of observing distance, the hand hygiene, the coughing etiquettes, and yes, so those are some of the measures that were put in place. And specifically, Uganda Red Cross is supporting risk communication within the refugee context. We have a number of volunteers that have been trained and they're in the refugee settlements doing risk communication. Now, risk communication at community level, traditionally Uganda Red Cross, we used to do door-to-door and holding group meetings, so that has had to be changed quite a lot because of social distancing. So now we use megaphones going around the community talking on loudspeakers about the risk of COVID and how it can be prevented.
Thank you so much. Neil. Neil?
It's still muted. It is unmuted now. Thank you. The question to me was on the strategy in relation to there being no contact tracing. There was a phased response in the UK, which started with intensive contact tracing at the contain phase. But once we got to widespread community containment, then the number of new cases meant that contact tracing wasn't possible. The plan is to reintroduce contact tracing once the level of new infections decreases as a result of the lockdown, in which case we will then try to identify any new infections and trace contacts and ensure isolation is taking place. So contact tracing definitely will be reintroduced, but we are piloting also sort of technology using mobile phones, which will rely on self-reporting of symptoms, and if 25% of the population get up to utilizing these, then we've seen that those can be effective in terms of alerting people when they've been exposed to potential infections. So some of these are innovative pilots. Just one quick comment on mental health. We've seen a huge increase in domestic violence in the UK, and mental health and stress to people in isolation is a critically important issue that I think it's important that we are aware of, and therefore broader mental health messages to try to encourage people to seek help for mental health challenges and to provide support is an important part of being prepared for and responding to this crisis. So very good to have that mental health issue raised. Over.
Thank you. John, you have a comment or two on the questions?
So no, if that was addressed to me, nothing to add. Those were really clear answers.
Thank you very much. Colleagues, now that we've finished that discussion, we need to go to the next steps and the role of health partnerships. Dr. Sheba Jita is going to give us some thoughts on the next steps. And this should take us less than 10 minutes. Dr. Jita?
Thank you, Prof. Henry, may I have my slides up, please? Okay, as I wait for the slides, basically, the talk is about health partnerships at a time of COVID-19, And we start off by defining what the health partnership model really is. And I want to draw your attention to the definition by the World Health Organization. Go back one slide, Solomon. Next slide. Next slide, Solomon, please. So a health partnership is basically a collaborative relationship that is based on mutual trust, and there is a shared goal. And FET has been undertaking health partnerships for over 30 years. And our health partnerships are long-term, sustainable and institutional relationships between health institutions in the UK and counterparts in low and middle income countries like Uganda. Our partnerships work within the healthcare systems to provide discrete and tailored projects. Normally, with the intent of these being long-term, we look at having them for 1 to 3 years, but many go on to renew. And they address a specific need that is identified concurrently by both partners and must address the need of the low or middle income country. Since 2011, FET has been managing UK's largest health partnership program. And just to draw your attention, our impact since 2011, we've been able to train over 100,000 health workers in 31 countries across Africa and Asia, and have contributed to a development of 117 medical curricula. Okay, so I thought it would be good for us to draw lessons from what happened during the West Africa Ebola outbreak. And one well-documented case study of a health partnership that worked really well is one between Connaught Hospital in Sierra Leone and the King's Health Partners in the UK. And the lead partner on the King's Health Partners side is King's College London, and there are 3 other hospitals within South London that are part of this partnership. Now, this health partnership started in 2013, and it was on invitation of colleagues from Sierra Leone. As you all know, the Ebola virus disease outbreak began in 2014. And when that happened, the focus of the health partnership which was largely initially to build health training within the country to strengthen the hospital and to be able to train medical doctors at both undergraduate and postgraduate level, moved towards responding to the Ebola outbreak. And some of the outputs that were delivered during this outbreak were the partnership members were co-opted onto the National Ebola Task Force. And as part of that team, they drew upon the expertise of the health workers from UK who are part of the team working at Connaught Hospital to contribute towards designing different protocols. Again, under this partnership, they were able to take the lead in training health workers, not only for Connaught Hospital, but also for other NGOs and facilities within the western region of Sierra Leone. And after the outbreak, they were able to transform this into a center of excellence on infectious disease training. They participated in case management, surveillance, laboratory services, and they were very critical in establishing Ebola holding unit.
Hello. We have lost Sheba. Sheba, Henry, can you?
Yes, Professor, I think we have lost. Yes, I can hear you, Professor.
So we've lost Sheba.
But I think we have lost Sheba, and I think at that point we could maybe proceed to the next step. Yes, we've lost her. Maybe she will come back. Possibly she has a network problem.
So Professor Gerard Ban, it's your time to give some closing remarks in the last 9 minutes or so.
Good afternoon, all. I'm absolutely delighted to be here, and I have to say we're completely blown away by the quality and depth of the discussion over the last hour and a half. Just some observations from me, really, and of course technology has somewhat thwarted the Tropical Health and Education Trust's description of the valuable role that they've played over the years in strengthening the relationships between institutions in Uganda and institutions in the UK. And I'm very proud, as well as being the chair or the co-chair of the Uganda UK Health Alliance, which has organised this a fantastic webinar, but also being a THET trustee, which I think is a real privilege and an honour. The thing that struck me more than anything else, really, are two things, I guess. The first is how easy it is as a clinician or even a citizen of a country to become introverted when something on the scale of the COVID-19 pandemic hits the world. And certainly my observations, again, as a practicing clinician, was that in the very first throes of where we realized that the world was about to hit something that it had not seen for the best part of 100 years, that most of the conversation focused very much on local communities, local community response. And how local hospitals could be staffed appropriately. I think there was great danger in this because the reality is that pandemic by definition is something that every citizen across the world has to face in equal measure. And whilst we all have our own health systems on our own concerns, history tells us that by co-developing in healthcare, we effectively create much better, more effective preventative interventions and therapeutic interventions. And I guess nowhere is more true it has never been more true that we must maintain our relationships and strengthen our relationships across country boundaries to fight the current epidemic that we are facing. It is also really quite amazing to listen to the conversations repeat themselves, whether you're a Ugandan citizen, a citizen of East Africa, a citizen of South America, a citizen of the UK or Europe. and the topics of PPE, antigen and antibody testing, who and when, border controls, quarantine, and fundamentally managing the unknown, as well as new expressions such as flattening the curve to reduce pressure on existing healthcare systems, are common to all of us. And I'm quite convinced that sharing the information, as we have done this afternoon, strengthens the resolve to create the atmosphere to not only defeat the current pandemic, but also to prepare ourselves as a world for any future pandemics that we might face. So I am really very, very grateful for, I think there's was at one stage 180 participants on this this webinar, for all of your attendance. And I'm particularly grateful for the Uganda UK team based in Kampala, and for specifically for Henry and Solomon, who put so much effort into developing this. So thank you all for your time, Nelson for your chairmanship, and it's really great to hear from some really important speakers such as Neil and Francis and Mark and etc. So thank you all for your time, and hopefully things will improve very, very rapidly, and we will meet again very shortly.
Thank you very much, Professor Ban. I'm feeling very sorry that Sheba's presentation was cut short. But if those who are still listening, if you don't mind, we could give her some 3-4 minutes if she's back on to just round up her presentation, since partnership is so important, as has been mentioned by Professor Ban. So is Sheba there again? Henry, can you locate Sheba?
Yes, Sheba came back, and I think she's able to give her presentation again. She said just in a short time.
Yeah,
Sheba,
so Sheba,
Okay.
can you shorten the presentation so that we finish at 5:30 or at 5:31 at most?
yeah.
So as they pull up my slides, kindly let me know once the slides are up. I'll just continue speaking.
Okay.
So based on that experience that we can draw from the health partnership in Sierra Leone, you can clearly see that there is a benefit in having, leveraging these opportunities of health partnerships. So as said, what we've done since the outbreak, what we've done since the onset of COVID-19, one of the things we did was to rapidly undertake a survey. Maybe just one slide behind. We did a survey with 20 of our health partnerships to identify what was going on and any opportunities. And based on that survey, we're able to answer this question: how our health partnerships can add value. So one of the ways is by rapidly identifying priorities to support countries. Okay, the second value add is by providing training and advice through virtual means, as well as with established partners, sharing and signposting to training resources and tools, and then providing psychological support and standing in solidarity. I think it has been mentioned by other speakers, the stress that the health workers are facing that are on the front line. And in response, this is what we have done. We have launched a health worker action fund. We are catalyzing wider health partnership community action, working with international partners to raise support for our partners in low and middle income countries. And we are capturing learning and insight to inform future health partnership approaches. Next slide. Okay, so I'll draw your attention to an example of how we are catalyzing these partnerships. The first one is the Brighton Lusaka Health Link, where in response to the COVID, Partners from the UK are supporting their colleagues in Zambia through weekly Zoom calls. Then I'll quickly move to the Nottingham Trent University and Makerere University School of Public Health Partnership. Again, this is a very long-standing partnership over 10 years, and they've done several projects. But of interest in this meeting, I'll draw your attention to the one on strengthening antimicrobial stewardship in Wakiso district that is funded under the Commonwealth Partnerships for Antimicrobial Stewardship. Under this project, the aim is to build capacity of health workers, including community health workers. There's stakeholder engagement and knowledge exchange. Now, with the onset of COVID, the community workers that were trained are actively engaged in different activities. Next slide, please.
We need to close in some 2 minutes.
Yes. So just to draw your attention to how we can leverage resources, as you can see, as part of the project, we donated motorbikes, and then currently those motorbikes are being used by the community health workers to undertake surveillance, community surveillance. We also donated hand washing facilities that you can see in the different photos. These have been stationed at public points like the trading centers, at the landing sites, and these are helping communities practice proper hand hygiene. We are having a conference on Saturday. Just go back one step, one slide, yes. So this coming Saturday, in an effort to work with international partners to raise support for actors in low and middle income countries, we are holding a webinar or a virtual conference titled Partnerships in a Time of COVID-19. And you are all welcome to participate in it. We are conducting this in collaboration with the ESTA Alliance as well as the WHO. Next slide. This is, I think, the most exciting part of our work. We've put together this Health Work Action Fund with the aim of protecting physical and mental health of our frontline workers. And health partnerships are eligible to apply for a maximum of £5,000. And the priority is going towards those partnerships that will be able to use these funds in a timely manner, so a short turnaround time. This call opened up on Monday the 20th, and we'll be accepting applications on a rolling basis, and we'll do our best to review these in a very short time so that you're able to hear back from us as soon as possible. And we expect funds will be used to support any initiative for no longer than 6 months, and after that you're eligible to apply for another round. Next slide. These funds, Uganda is one of the eligible countries, and the other countries are listed there on the left. And the most critical requirement is we are funding health partnerships that we've supported before, and those partners must have a good track record of conducting projects to a high satisfactory level and prudence in managing funds. Next slide. So you can get more information on the Health Work Action Fund. So in summary, I think the health partnerships are very critical because we are able to leverage resources, existing resources, that is technical expertise, draw on essential and non-essential supplies as well as research. They will be very critical for sharing lessons, especially UK is ahead of Uganda in the outbreak. So there is a lot we can learn from our colleagues in what you're doing to reintegrate the patients. And in return, we can share also our experience, but most importantly, expressing solidarity and providing peer support. As health workers at the front line, both in the UK and Uganda, I think this is a great opportunity that can be achieved through a health partnership. Thank you, Chair, for the opportunity.
Thank you very much for this presentation. On my part, I want to bring this to a close by saying thank you to the organizers of this webinar and to all speakers and panelists who have participated actively, and to the audience that have fielded questions that have been responded to. We are sorry that we are not able to, because of time, to respond to all the questions that have been fielded. At this point, I want to give opportunity to Henry Muwonge, the country lead for the Uganda-UK Alliance, to give the last word and explain whether this webinar has been recorded and how people can access it and when. Over to you, Henry. Otherwise, thank you very much for your attendance, and that's all from me. Henry.
Thank you very much, Chair. I am so grateful for your wonderful chairing. It's been a wonderful 2 hours that we have taken. Sorry, it's been long, but I believe there's been a lot of learning to everyone. I thank my team that I've worked with here in Uganda. That is Dr. Solomon Kamlari and Mr. Odonkara Timothy. You've not seen him here. He's our ICT manager. They have worked tirelessly over the last couple of weeks to ensure that this webinar happens, the way it has happened. Thank you very much, Professor Jed, for your support, and for the rest of the board members of Uganda UK Health Alliance, who include the chair himself, Professor Nelson. And to the speakers, I'm so grateful. Thank you for taking off the time to give us this time that you have taken to speak to the rest of the audience. And panelists, we appreciate your time as well. The webinar has been recorded, and we will share this video as soon as possible. Some clips will be shared as soon as possible via the Uganda UK Health Alliance website, and we hope that should happen maybe by the end of next week latest. We will also compile a written report that should come out by early next week latest, but we hope by the end of this week we must have that report out and it will be shared widely through the Uganda UK Health Alliance website. I would want to encourage everyone that has attended to share with us articles at any point in time. We are also working on a newsletter, so some of these things that you have asked, some of the things you've deliberated on are going to be passed out and published via a newsletter. Thank you very much. We shall also do a survey. We will request everyone that has attended, when we send you questions on this survey, because we want to generate evidence on subsequent webinars, because we know this wasn't enough time for everything to be deliberated on, but we think if we do a survey, you will give us more information on how this should be done. We want to know where the weaknesses were, where the strengths were, and what we should make better. Thank you very much, Chair. I want to take this opportunity to thank everyone and to wish everyone a good evening. Thank you.